Question 1. A 79-year-old man is admitted to the ICU after a massive intracerebral hemorrhage. He is deeply comatose, GCS-3, ventilator-dependent, and has no brainstem reflexes. 2 independent neurological assessments confirm brain death according to national guidelines. The patient has no documented advance directive. His family insists on continuing full organ support, believing he might still wake up. The ICU is at full capacity, and a patient with potentially reversible septic shock is awaiting an ICU bed. Which of the following is the most ethically and legally appropriate action for the ICU team? Continue full life-sustaining treatment until the family agrees to withdrawal. B. Withdraw organ support as the patient is legally dead after explaining findings to the family. C. Seek ethical and legal team intervention before discontinuing treatment. Transfer the patient to another ICU to honor the family's wishes. Continue current care and initiate palliative sedation to reduce family distress. Correct answer is B. Withdraw organ support as the patient is legally dead after explaining findings to the family. Explanation. In most jurisdictions, brain death equals legal death, meaning there is no ethical or legal obligation to continue organ support. Once death has been confirmed according to accepted medical and legal criteria, continuing mechanical ventilation is equivalent to supporting a corpse. It is not life support in the ethical sense. Withdrawal of organ support aligns with both ethical principles, non-maleficence, justice, professional integrity, and legal standards. Family should be fully informed and supported, but withdrawal is not contingent on their permission. Key message. In ICU ethics, once death is determined according to accepted criteria, the duty shifts from sustaining life to ensuring dignified withdrawal of organ support, with transparent communication and emotional support for the family, but without delaying necessary actions or compromising care for other patients. Question 2. A 36-year-old woman with no previous liver disease is admitted to the ICU with acute liver failure due to paracetamol, acetaminophen, overdose. On day 2, she becomes increasingly confused and agitated. Findings. GCS, 9, E3V2M4. INR, 5.6. Bilirubin, 250 micromole per liter, 14.6 milligrams per deciliter. Ammonia, 150 micromole per liter, normal less than 50. Creatinine, 190 micromole per liter, 2.1 milligrams per deciliter. Serum sodium, 138 millimole per liter. MAP, 72 millimeters of mercury on norepinephrine 0.06 microgram per kg per minute. CT head, no intracranial bleed. Which of the following is the most appropriate immediate intervention to reduce the risk of secondary brain injury in this patient? Start prophylactic mannitol infusion to prevent intracranial hypertension. B. Initiate mild hypernatremia. Target serum sodium 145 to 150 millimoles per liter with hypertonic saline infusion. C. Give empirical broad-spectrum antibiotics for possible sepsis. D. Perform urgent transjugular intrahepatic portosystemic shunt, TIPS. Administer fresh frozen plasma to correct coagulopathy and lower INR. Correct answer is B. Initiate mild hypernatremia. Target sodium 145 to 150 millimoles per liter with hypertonic saline infusion. Explanation. Acute liver failure carries a high risk of cerebral edema and intracranial hypertension, particularly in grade 3 to 4 hepatic encephalopathy. The patient's rising ammonia, coagulopathy, renal dysfunction, and encephalopathy indicate severe acute liver failure with imminent risk of cerebral herniation. Management priorities is to prevent secondary brain injury by controlling cerebral edema. Hyperosmolar therapy is used prophylactically in high-risk acute liver failure patients. Mild hypernatremia, 145 to 150 millimoles per liter, with hypertonic saline infusion reduces cerebral edema risk. Mannitol is generally reserved for documented intracranial hypertension, not prophylaxis. Empirical antibiotics are considered if infection is suspected, but infection is not the primary cause of the neurological decline here. TIPS is contraindicated in acute liver failure and may worsen encephalopathy. Correcting INR with FFP is not recommended unless active bleeding or before invasive procedures. Routine correction does not reduce bleeding risk and may increase volume overload. Key message: in acute liver failure patients with advanced encephalopathy, prevention of cerebral edema with targeted hypernatremia is a key immediate intervention while awaiting definitive therapy, for example, liver transplantation. Question 3. A 29-year-old man is admitted to the ICU after being found unconscious at home with an empty bottle of amitriptyline, tricyclic antidepressant. On arrival, GCS 6E1V1M4, BP 80/50 mmHg, heart rate 140 beats per minute, respiratory rate 8 per min, on bag mask ventilation, saturation 92% on high-flow O2. ECG, QRS duration 160 milliseconds, sinus tachycardia, terminal R wave in AVR. ABG, pH 7.12, partial pressure of arterial CO2 55 mm of mercury, bicarbonate 18 millimoles per liter, lactate 4.5 millimoles per liter. After intubation and ventilation, what is the most appropriate immediate pharmacological intervention? A. Intravenous magnesium sulfate. B. Intravenous sodium bicarbonate bolus. C. Intravenous calcium gluconate. D. Intravenous lipid emulsion therapy. E. Intravenous amiodarone. Correct answer is B. Intravenous sodium bicarbonate bolus. Explanation: this patient has severe tricyclic antidepressant poisoning with CNS depression, low GCS, hemodynamic instability, hypotension, tachycardia, ventricular conduction delay and acidosis, pH 7.12. Tricyclic antidepressants block myocardial fast sodium channels leading to QRS widening, risk of ventricular arrhythmias, and hypotension. Acidosis increases drug binding to sodium channels, worsening conduction delay. Evidence-based treatment includes sodium bicarbonate, which is first-line therapy for hemodynamic instability or QRS widening. Sodium bicarbonate increases serum pH, hence reducing drug binding to sodium channels and provides sodium load to overcome channel blockade. Dose is intravenous bolus, 1 to 2 millimole per kg. Repeat as needed, followed by infusion if indicated. Lipid emulsion therapy is possible in refractory cases after sodium bicarbonate, but not first-line. Amiodarone is not recommended for tricyclic antidepressants-induced arrhythmias. Key message: in severe tricyclic antidepressant poisoning with QRS widening and acidosis, intravenous sodium bicarbonate is the critical immediate intervention to stabilize conduction and improve hemodynamics. Question 4. A 42-year-old woman with known Addison's disease is admitted to the ICU with confusion, hypotension, and fever. She has been on oral hydrocortisone and fludrocortisone but recently had severe gastroenteritis with poor oral intake for 3 days. Findings: BP 78/50 mm of mercury, mean arterial pressure 60, despite 2-liter crystalloid infusion. Heart rate 120 beats per minute. Temperature 38.4 degrees Celsius. Sodium 124 millimole per liter. Potassium 6.2 millimole per liter. Glucose 2.9 millimole per liter, 52 milligrams per deciliter. ABG, pH 7.28, bicarbonate 16 millimole per liter, lactate 3.5 millimole per liter. Blood cultures pending. What is the most appropriate immediate next step in management? Start norepinephrine infusion and arrange urgent endocrine review. B. Administer intravenous hydrocortisone 100 mg bolus followed by continuous infusion or every 6-hour dosing. C. Give 10 units intravenous insulin with dextrose to treat hyperkalemia, then reassess. D. Start broad-spectrum antibiotics before any steroid administration. Administer fludrocortisone 0.1 mg orally via NG tube immediately. Correct answer is B. Administer intravenous hydrocortisone 100 mg bolus followed by continuous infusion or every 6-hour dosing. Explanation: the patient has adrenal crisis, acute adrenal insufficiency, in the context of Addison's disease, precipitated by infection and poor steroid intake. Key features: hypotension refractory to fluids, hyponatremia, hyperkalemia, hypoglycemia, metabolic acidosis. Immediate priorities is to administer stress-dose glucocorticoids, intravenous hydrocortisone 100 mg bolus, then 200 mg per day either as continuous infusion or divided every 6-hour. This addresses glucocorticoid deficiency and provides mineralocorticoid effect at high doses, so fludrocortisone not needed acutely. Treat precipitating cause, for example, sepsis, after stabilizing with steroids and fluids. Correct hypoglycemia and electrolyte disturbances, but these are secondary to immediate life-saving steroid therapy. Vasopressors are often ineffective until steroid deficiency is corrected. This delays definitive therapy. Sepsis is likely, but in adrenal crisis, delaying steroids for antibiotic administration risks death from refractory shock. Both can be started quickly, but steroids must not be delayed. Key message: in adrenal crisis, give intravenous hydrocortisone immediately, alongside fluid resuscitation, glucose correction, and treatment of the precipitating cause. Vasopressors and other measures are adjunctive, not primary. Question 5. A 34-year-old woman with a history of systemic lupus erythematosus presents to the ICU with rapidly progressive dyspnea, fever, and confusion. She was diagnosed with lupus nephritis 2 years ago but has been non-adherent to immunosuppressive therapy. Findings: BP 92/56 mmHg, mean arterial pressure 68. Heart rate 118 beats per minute. Temperature 38.8 degrees Celsius. Saturation 88% on high-flow oxygen. Physical exam: malar rash, bilateral crackles, mild pedal edema. Labs: HB 8.6 gram per deciliter. Platelets 42,000. Creatinine 285 micromole per liter, 3.2 mg per deciliter. LDH 980 unit per liter. Haptoglobin undetectable. Respiratory count elevated. Direct Coombs test positive. Chest X-ray bilateral alveolar infiltrates. ABG partial pressure of arterial oxygen/FiO2 ratio equals 140 millimeters of mercury. Which of the following is the most urgent initial intervention in this patient's ICU management? Start broad-spectrum antibiotics for possible pneumonia. B. Initiate high-dose intravenous methylprednisolone. C. Perform urgent plasmapheresis. Transfuse packed red blood cells to HB greater than 10 gram per deciliter. Start therapeutic anticoagulation with unfractionated heparin. Correct answer is B. Initiate high-dose intravenous methylprednisolone. Explanation: this patient has acute severe lupus flare with multi-organ involvement. Pulmonary, likely lupus pneumonitis or diffuse alveolar hemorrhage, bilateral infiltrates, hypoxemia. Renal, lupus nephritis relapse, elevated creatinine. Hematologic, autoimmune hemolytic anemia, Coombs positive, low haptoglobin, high LDH, reticulocytosis, and thrombocytopenia. Why steroids first? This is a rheumatological emergency with high mortality if not treated rapidly. High-dose intravenous methylprednisolone, for example, 1 gram per day for 3 days, is the immediate therapy to suppress immune-mediated damage. Plasmapheresis may be considered later if there is refractory disease or associated catastrophic antiphospholipid syndrome. Broad-spectrum antibiotics may be started concurrently if infection is suspected, but delaying immunosuppression in a fulminant lupus flare worsens prognosis. Key message: in severe multi-organ lupus flare, start high-dose intravenous steroids immediately to halt immune-mediated damage, while also evaluating for infection and other complications.